to join. I think we've got a quorum here, so I'm going to call the meeting to order, and then I'll just go down the roster and respond present, so Connie can get attendance recorded. So Sandra?
Here.
Robin?
Here.
Gary?
Here.
Lori?
Here.
Monica? I think she had a conflict. She might try to join later. Sarah?
Sarah's running late too, I think.
Okay. Mike Brower?
Here.
Mike Kagi? Keith Richard? Jason?
Here.
Well, good morning. Before we get started here, I'm just thinking this morning, I very much want to thank the staff, from Sunflower and from the Attorney General's office for their efforts, and it's really been a joy working with both of them. And then also the board members, for volunteering your time. I just crossed my mind this morning how, I've been on a lot of boards and committees, which I'm sure everybody has, but this one with, I don't know how to say it, the singleness of purpose of helping other people, especially those, suffering from addiction. Having been in recovery myself and worked in the field, there's certainly a lot of need, and seems like it's increasing, unfortunately. So to be part of a group of people that are trying to make a difference. And so anyway, thank you for your time and efforts, and we're really just getting started, and we got a lot of good things to look forward to doing and helping save lives and families. So with that being said, our first action item and only action item of the day is the approval of the December 8th board meeting minutes. Would entertain a motion.
So move to approve the minutes.
Robin motions. Second.
Second. Lori.
Second from Lori. Any discussion? No discussion. All in favor of the passage of the December board meeting minutes?
Aye.
Yay. Aye.
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 Raise your hands, do something. All opposed, same sign. All right, unanimous. Thank you. Chris is unable to be here, so Nancy from the Attorney General's office will update us on things going on over there. So Nancy, turn the floor over to you.
She's not here in the room. Is she in the virtual room?
I don't see her. Well, we can come back to her.
This is Keith. I am here. So.
Okay. Hey, Keith.
Sorry, I had a hard time connecting, but I'm here.
Good. Well, we'll just skip over the update from the Attorney General's office. I don't think there's a lot to share there, but we'll get back to that if Nancy comes on. I know they've got a lot of things going on over there. So we'll turn now to item number 4 on the agenda, and that's the update on our grant awards and needs assessment. And Alicia or Krista?
Yeah, sounds good. And I'll let you know if she does come in so that we can go back to that agenda item for Nancy. So grantee updates really quick. Not a whole lot of updates since our last meeting. We're still waiting on the paperwork for the final 2, just working through some red tape still with their organization. We processed the second round of treatment grantee payments in December. That was about 32 payments for just a little under $2 million that was paid out. And then the first round of progress reports are due on March 31st, so we'll have a lot more information hopefully after those first set of progress reports came in, and then I will pass it over to Alyssa for the needs assessment.
Good morning. So the needs assessment has been going well. We at Sunflower Foundation, Krista and I have continued to meet with CPPR's team to discuss project logistics since the last board meeting in December. Currently, we're meeting weekly with their team just to make sure that we're staying aligned and that we're able to move forward in a way that maximizes and is most efficient with our time. Currently, we are working with them on planning the community and stakeholder engagement opportunities that will be occurring. A big piece of this will be monthly public open webinars that CPPR will be hosting. And we are aiming to host the first webinar near the end of January or the beginning of February. We will be meeting with their team later today. And so hopefully we will be able to get some more information out about that soon. And that is all of our updates.
Thank you. Questions for Krista or Alicia? You know, I suppose at some point here in the next meeting or in a couple meetings, we might have a more update and maybe even bring in the KU folks if the board wishes to, as we go down the line putting this needs assessment together. It's really going to be foundational to what we do for the years coming up. So would probably look to doing that. Seeing no questions, thank you very much for the update, and we will move to item number 5, which is just report on the annual report that we present to the legislature. I know that our Sunflower and the AG's office been working on this report that we'll present for approval, I believe, at our February meeting, and then have it distributed to the legislature and the executive branch. So Krista, any update in that regard?
Yeah, so I was just going to give you a rundown of what's in the new annual report since our first one was pretty basic. And I do plan on getting that out in advance of the February meeting so the board members have time to review it before the February board meeting since it's due March 1. And Chris did mention if there are a lot of changes and revisions, we might have to have an interim meeting in between the February and March meeting to finalize the report if we're not able to get through it at the February meeting. So just a heads up there. So differences with the annual reports, the introduction section is basically the same as it was last year until we get down to the financials. Last year, we only had funds that went to the Attorney General's office and K-Trax from the funds and the initial payments to the municipalities that went out, and then the rest was just listed as allocated because they hadn't actually been distributed from the funds yet, and so there was very little to report financially the first time. So now the second one has a summary of amounts received from the settlements for 22 and 23 to start, so what the state has received from each of the settlement payers, and then as well as they're including for both KFAF and the MFAF for both years, 22 and 2023. So we have financial reports that right now in there, we have 4 different ones that show the allocations and expenditures for both of those years and totals, receipts by settlement, fund analysis showing the starting balance, receipts, interest, allocations, and expenditures or distributions made for both KFAF and MFAF, and a cash balance summary for both. So that's kind of what those financials are looking like for the reports. We're still working on those. And then a narrative description will follow those two to describe what's in those tables. Following the financial section, we move into the KFA specific section where we describe all of the funding awarded and the board activity for the last year, including a list of meetings. And right now I have a summary of all of the actions and activities for each meetings in there. You all might decide that's too much or too little information, so we can fix that as well at the next meeting to see what you guys want there. Followed by that is a narrative of all of the KFA RFPs and the grants summarizing processes and procedures that you all developed over the year and how and what strategies were selected and included in those RFPs. how applications were reviewed and the due diligence that was conducted, a summary of the awards, and then some graphs from that impact report that show that we met the 1/8 threshold for each congressional district with the funding for the year, and where applicants were targeting, such as the congressional districts and the counties, as well as the breakdown by the priority areas like prevention, treatment, recovery, et cetera. So we have those 4 graphs in there as well right now. Followed by that is the needs assessment process and progress update section, and then the board compliance statement from Pat, which is the same as last year. And then the appendix will have the following information for each grant. So it has the organization name, organization type, so either government or 501c3 or nonprofit entity, congressional district served, amount awarded, priority areas addressed, and then a detailed description of the organization as required by the statute. So we pulled those from the applications as well, with the project title, summary, and counties served. So that's what the annual report includes so far. If you have any questions.
Questions for Krista? Thank you, and I'll just remark, I had no idea what all went into the legislative annual reports until I spent some time at the Department of Commerce, and we had several programs that required annual reports, and I was just blown away by the effort and the work and the information that went into those reports. So again, thank you to the staff at Sunflower and Krista for putting the main bulk of that together. And we will, if at all possible, get a draft out to the board before the next meeting, and then entertain any changes that we need to make before we present that as required by law. So thank you. And we're moving right along here, which I appreciate. Any comments, I guess? Did Nancy from the AG's office, did she happen to come in virtually? Yep. Or?
Yep, she's here in person and ready to go. She's actually seated now.
Okay, great. Well, thanks for coming over. And again, I know Chris had a conflict. He's not here. So any update that you might have as far as the opioid settlement that you want to share with us?
Yes. Good morning. Sorry to be late. We have received the final distribution from Mallinckrodt as part of the bankruptcy process, and we anticipate to making a distribution to the cities and counties in the next month from this final payment. We're also continuing to monitor the Purdue bankruptcy proceedings in Supreme Court. We're starting our reach out process to get cities and counties to submit their annual reports of opioid receipts and expenditures. Those will be due by March. If all goes well, we'll have that report ready for discussion at the March meeting. Finally, we have received multiple communications from the public curious about the next rounds of grants. If any board member has any additional questions, feel free to contact Chris.
Thank you. With that being said, and that report, again, I appreciate you coming, braving the cold to come over. And if you do have any questions, we can get those to Chris and get you answers. So just send me an email or Krista, or to Chris directly. He's always accessible.
So Pat, this is Keith. What's the answer to that question about the next round of grants for either treatment or prevention? Or it'll be in the fall again on an annual basis, or have we decided?
You know, we haven't decided. Actually, glad you asked that, Keith. I was thinking about that last night. My thought would be that at our next board meeting, we decide if we want to do, I don't know how to determine an interim grant, either based on what we've already put together or, another area of emphasis. So I'm certainly open to doing something sooner. You know, we have the funds, and it's going to be a while before we get our needs assessment, but that doesn't mean that there's not immediate needs. So we'll make that a topic, an agenda item for the next meeting. Keith.
Okay, thanks, Pat.
Any other questions? Okay, well, item number 6, Brittany Garrett. And Brittany, you're the Senior Director of Public Safety Engagement and Strategy for Perry, Police Assisted Addiction and Recovery Initiative. So I'll say the titles and introduce you, but really looking forward to this presentation. I have not had direct experience with Perry, but I've had a lot of experience with people that have worked with this particular initiative, and I know they've done a lot of good. So looking forward to your presentation today, and I'll just turn it over to you.
Thank you so much. I appreciate it. I apologize for my voice. I've been sick all week, so I might be taking some cough drops and some water breaks as I present today. But thank you so much for having me. I'm really excited to talk today, and thanks to Todd as well for inviting us in and for the conversation around all of this. I appreciate you sharing my slides too. You can go ahead and go to the next one. That'd be great. I'm really excited. One, thanks to the Opioid Response Network. We're really lucky to be able to work with the Opioid Response Network and utilize a lot of their resources, but that's how we were able to connect with Todd today. If anybody ever has questions about training or consultation efforts related to opioid and stimulant use, opioidresponsenetwork.org is a great way to do it. So we just want to thank them for letting us be here today. Next slide, please. So why I'm here is really to start talking about police and public health partnerships. Just as a little bit of background on me, I'm a former law enforcement officer from Kentucky. I'm still based out of Kentucky. PARI, the organization I work for, is a national organization that started in Massachusetts, which I'll talk about in a little bit. But really, the foundation of the nonprofit that I work for and the work that we do every day is the importance of police and public health partnerships. And when I say police, I'm talking public safety too, fire, EMS, working together with public health and behavioral health to really provide a more robust response to the opioid epidemic, opioid and addiction crisis. Really what it comes down to is developing smart policing and community policing programs so that we can help increase the safety and health of our community. I know that locally, all the way across to different communities, we've all felt the similar ramifications of this specific opioid and addiction crisis. But what I'll talk about today is a lot of programs and ways that those partnerships have really been vital to developing and implementing programs to support the health and safety of communities. One statistic that I do like to talk about is, public health emergencies are still being responded to by public safety. A really conservative estimate is about 20% of those calls for service involve a mental health or substance use crisis. I would, if there's more data out there, I've seen some that go into 30% or 40% of calls for service. So there's a lot of research talking about the importance of that overlap of work and how we can work together to be more efficient in how we're responding to those crises. Next slide, please. And I know that everyone's seen these numbers, but I think it's important to really understand the foundation of why we're having these conversations. What we looked at in 2015, our department in Kentucky started to think differently about this initiative around 2015, 2016. PARI was founded in 2015. So I like to use that as really as a benchmark of when we knew it was a crisis, when we knew we had to do something. And it was already far too late. In 2015, we were at around 52,000 deaths. And then we blink to what we're dealing with right now, and it's doubled in that amount of time. And not just about the opioid deaths that we're seeing out there. We know that fentanyl is increasing in our areas. We're seeing xylazine and those types of things in our supply that's making this worse. But I think one thing that's really important is looking at those non-fatal overdoses. In 2020 alone, the conservative estimate that those were about 600,000, and that number is people who actually went into the ER. We know that there are a lot of people who overdose and they don't go into the ER, so we know that number is likely higher than 600,000, but that's really an opportunity of first responders are responding to those scenes, working with some of our public health partners to be able to provide interventions to reduce that number, and I'll talk a little bit more about that as we move along. Next slide, please. A little bit about PARI. So we started in 2015. There was a local police chief in Gloucester, Massachusetts. When I first started in this field, I didn't even know how to say Gloucester. It's a small fishing community about an hour outside of Boston. And they were having an inordinate amount of overdoses, crime related to specifically heroin and pills that were going on in the area. And the chief heard the calls of the community that something had to change. And he said, well, starting tomorrow, you can, people can walk into our police department and we will get them connected to resources instead of going down those traditional pathways, which often ended up in jail or high utilizing systems like the ER. They did a Facebook post that ended up going viral, and they were quickly overwhelmed with tons of other departments wanting to know what they're doing, how they're doing it. The first person that walked in the door there actually came from California. Somebody in California read this and bought a plane ticket for somebody who was suffering from substance use disorder, sent them all the way to Gloucester to get help. And to show the impact that a police department can do in moving this forward, it's just incredible to know that they were able to navigate treatment and care for that person. And that first person actually came back and worked in the program years later after they were able to get help and get into recovery. This initial program was called the Angel Initiative. When that chief was overwhelmed overnight, he reached out to some local business partners that have had nonprofits in various areas, and they started the Police Assisted Addiction Recovery Initiative to support those local efforts and then expand to more departments. Quickly, within that first month, there's another department not too far away in Arlington, Massachusetts, that was doing an overdose outreach program. Very, very early, very new. Not many places were doing that. And it just was rapid fire after that. This started really a nationwide movement that quickly expanded to include overdose outreach, peer support, active outreach, and other initiatives across the country. My police department in Kentucky was actually the 100th police department to join this network. And our program that we started in 2016 is better than it ever was. It's really robust. And what we started with just one person moving this forward, now there's a unit that's dedicated to doing this work. Today, more than 700 police and public safety agencies across the country are part of our network and are doing just some amazing solutions with public health and behavioral health to really combat this crisis. Next slide, please. When I talk a little bit about the impact, what we want to show is that we actually just yesterday got our 45th state. I haven't been able to update this map just yet because of that, but we're now in South Dakota and North Dakota within this the last couple of months. And really, the whole purpose of what we do and why I'm here talking today is to really spread information about what people are doing, to show how we can help, and to hopefully, inform some decisions that might be made moving forward with how to create programs in your area. This just shows, that we've distributed naloxone, fentanyl test strips, and those type of things. We also elevate the national voice. We have a really close relationship with the Office of Drug Control Policy at the national level, and helping, talk about and elevate the voice of first responders working in this field and how we can work together. We have a yearly summit as well. We just completed it in December. It was a great turnout. Just showing a little bit of what we do and technical assistance and webinars and resources for our departments as well. Next slide, please. So really the crux of what I really want to get to is, and it requires us to all kind of speak the same language. And I know that I can't see everybody, so it's hard to tell, but how many people have heard of the word deflection? Is that kind of new for a lot of people? A few people have heard. And I've noticed that in a few places. So I'd like to kind of talk about the difference and how oftentimes these two types of programs work together. Deflection is really a new term that's really been born out in the last handful of years. And it's really talking about trying to engage people before they get into those higher utilizing systems, like getting into our jail systems, getting into our emergency response systems. It's really about not resulting in arrests and typically not involving criminal justice mechanisms, but it's about contacting, if there's a contact with an officer in the field, it's there's typically not a criminal offense that has been occurred, or it's a lower level offense and there's no intention to arrest. So it's about being able to hand off to treatment in the area. Individuals voluntarily work with those deflection teams to access treatment or services. In diversion, typically what we see is those are contacted during enforcement activities where there's potential for arrest. There's pre-arrest, post-arrest diversion. We're all very familiar with treatment courts and a variety of different type of diversions that happen. But what I'm going to focus really mostly on today is deflection programming and the research that we're seeing and the programs that we're seeing out there that are grabbing people before they get into those higher utilizing systems, before they continue in those higher utilizing systems. Next slide, please. This is just another graphic to kind of show the difference between deflection and diversion. I just include this here so you can see what typically there's no charge on the deflection side of it. In diversion, there is typically a charge, and there's something that has to be completed in order to get rid of those charges, dismiss those charges in court. Next slide, please. This is one of my favorite graphics to really understand this. And this is when, from a law enforcement background, I was able to to better understand what the treatment center modality is and how we think about how we intersect with individuals in the community. I understand completely how courts work, how to arrest someone and the pathways to go through that stuff, but I didn't really understand that those same moments that we have contact in the community, from our crisis lines to 911 to law enforcement to court, are the same interventions that we can use to be able to interact and intercept individuals into treatment within the system. So this graphic, which is created by SAMHSA, which has a lot of really great support and resources out there, shows the continuum of the system. Most PARI programs focus on intercept 0 and 1 that point from the crisis lines to 911 and local law enforcement. So that's really what I'm going to focus on today. And you can see that there's that overlap between 0 and 1 with 911 and local law enforcement. So this just gives a little graphic so we can all kind of visually see what we're talking about today. Next slide, please. This just gives a broad overview of the different types of deflection models. I'm going to get into a few examples. We could be here for 2 more days if I talked about all the programs that are out there. I'm just going to hit some highlights to save everybody a lot of time sitting here and me talking. But really what this is about, these deflection models are all about connection to treatment and harm reduction resources at the end of the day. From this self-referral model that we talked about with Gloucester, that was you could walk into the police department, to something like post-overdose outreach, and overdose has occurred, and now teams are going to go out and follow up with that person and try to engage them with treatment. Community responder, trying to get people before they even touch the 911 systems or police. Co-response, which there is a great co-response model out of Johnson County, Kansas, doing this exact work, and really just building on that type of model, which is originally founded in mental health response, CIT, crisis intervention response. But we're seeing a lot of teams now branching to be able to grab the substance use aspect of it because they're so intertwined, but knowing that there's already great examples locally to look at. Active outreach is really that approach that we know something is probably going to occur in the field, that someone's at risk for overdose, someone's at risk with other social issues that could lead to criminality or overdose or other issues in the community, and being able to target that. We have great examples of mobile crisis vans and things like that that go out to be able to address an active approach. Alongside that is also hub situation tables, which is about bringing community members together to talk about important situations to be able to provide that outreach in the community. Next slide, please. Starting with community responder models, this is truly that intercept 0 that we're talking about here. I just want to briefly explain this, and I put these names in here as a way to get a little bit more information after the fact if you're looking at the slides and want to know about these great models. But really that is civilian crisis-led response. And so what we're seeing in a lot of, especially larger cities, we have it in the city that I live in Louisville, Kentucky, there's a crisis call deflection team that they're informed and they work together with law enforcement, but they are actually their own unit that goes out without law enforcement to respond to low-level issues related to mental health or addiction or other social issues like homelessness, where there's not a threat of violence or any other issues like that. a lot of times, especially in Denver, is a great example that they have this type of crisis response, but it is a part of a larger step forward. As we look at that intercept, they have this community response, they have a co-response, and they also have follow-up for things like post-overdose outreach to get people where they're at and really respond in real time to the needs of the community. I just throw that out there as an example of that first intercept, 0, to really see how community responders work. Next slide, please. We talked a little bit about self-referral. This is often the first step for a lot of police and public safety, but what we see now across the board is that the self-referral and first responder referral, which is officers and our first responders, our ambassadors in the field, that a pathway exists to connect people to resources, whether that's working with recovery coaches or peer supports, having a co-response or something like that. But the first responders are informed and know who to plug in whenever they're dealing with someone in the community that needs that resource. So a lot of times we see self-referral and first responder referral together. One example of a type of first responder referral is law enforcement assisted diversion, or LEAD. That's one type of pathway. There are 2 additional: social contact, as well as a community contact that can be used for this. But it's a way of working with those community organizations, having those foundational supports to be able to either, if somebody walks in, if you're out on a call for service, or somebody just flags down an officer, because a lot about this is about rapport building and trust building in communities. That I know when I was an officer and we had these programs, that people started to trust the officers, that we were able to help them get into resources. We're not always there to just put handcuffs on. We have enough knowledge and understanding of these resources to connect them to other things. I'll talk a little bit in more depth about a couple of programs as we move along, but I just wanted to highlight those here. Next slide, please. I think the one that I want to really focus on is Hope Not Handcuffs and additional Families Against Narcotics programs. This is really extraordinary what they've done there. They took the original idea of Gloucester, brought it to Michigan, and expanded it. And what they started in 2017, they've also replicated in New York as a multi-county initiative. It's now a statewide initiative in Michigan. They have more than 190 police departments, healthcare, and church locations for referrals, as well as an online option. It started as solely a self-referral walk-in type of situation, but now they have the online option. They have other referral options in the community, and officers are ambassadors to be able to connect to resources. They have to date more than 11,000 referrals to treatment, a robust network of volunteers to support efforts. They have a call center that they have staffed with peers. And this all sounds amazing, but when we're just getting started, it seems overwhelming. But they started with one idea in one city, and they've been able to branch this over the last few years to get that support and funding to be able to expand these efforts. One thing is incredible that I've seen in a lot of the research that they have is their law enforcement training showed increased knowledge and understanding of resources and reductions in stigma. So being able to interact with law enforcement and engage them in this process, they actually reduce stigma with the police officers that are out there in the field. The officers understood more about what their community was suffering from, what individuals are going through. And to me, as a former law enforcement officer, I know that it helped me have more value in my job every day, that I knew what people were going through. And so it allowed me to understand, well, why did that person not want help today? Why was it difficult that this person relapsed again? And it started to, by changing that, increasing our knowledge out in the field, it really made my job much more enjoyable. And it made me understand the people that I was interacting with on a day-to-day basis. The really cool thing that they had in their training as well, and with the data that they're getting from their outreach, is that persons with substance use disorder that interacted with law enforcement reported improved perception of police. And it's just absolutely incredible that across the board, people had just a complete, mindset change on interacting with law enforcement in this way. I think that's truly incredible thing that they've gotten from being able to do their program statewide at this point. Next slide, please. Incident-based and post-overdose response and active outreach. I have them on the same slide because, again, I'm talking about pathways here, But most of these programs share a lot of this information. They may be started with a post-overdose response, such as Plymouth County Outreach in Massachusetts. That means an overdose has occurred within 2 to 3 days. They go back out and try to make contact with that person and offer them services. It may be just naloxone or fentanyl test strips today, but it could also be a warm handoff or connection to inpatient treatment, outpatient treatment, and those type of things. Same thing with Coleraine Township in Ohio, the first quick response team. But what they also realized, they had people in the community that were like, hey, do I have to wait for, my son or daughter to overdose before you help them? And it took a second and they were like, you're right, that seems crazy that we have to wait for that. And so this active outreach mindset really started from that. It's targeted outreach before an incident. What they've been able to do is notify like at-risk individuals. Maybe an officer has arrested somebody 3 times for the same type of thing, and they know that they're at risk for overdose. From what we know from when people go into jail and they're at higher risk for overdose when they leave. Maybe it's somebody that is a social issue that will likely lead to victimization or potentially criminality. Being able to address addiction, mental health, and housing and other social issues. So hub situation tables are a great example of that. If we go to the next slide, I'll talk about a couple of examples of these programs that are really just incredible. One other thing really quickly is the community level evaluation of Massachusetts agencies. And these are police-led post-overdose outreach programs that this is really the first, one of the first publications that showed a 6% reduction in fatal overdose rates annually for each year of the program relative to non-adopting agencies. What this means is that these programs are working and that these programs are changing it's not just a program, I want to say too, it's changing the philosophy of how these communities are working together, how they're working closely between, public health, behavioral health. Before our initiative, we didn't even speak to the public health department. We didn't even know where they were at. And we were able to develop those relationships and understanding where we know where our lane is as law enforcement, and we can engage the people with the expertise in behavioral health and public health to be able to pull them in to help our communities in ways that we cannot. And so what we're seeing, I think this is a great publication to show that. And it leads into our first program on the next slide that I'll kind of talk about. In Massachusetts, which is one of the gold standards for community or countywide outreach in the country. They're a national COSAP mentor site at Plymouth County Outreach. They began in 2016. They had 27 municipalities. I know if it's anything like our community here, getting 28 police chiefs to agree on anything is pretty extraordinary. And they did it there. They got them all at the table, and they were able to develop a program where they have a police officer that's specifically trained, a peer and a clinician that follow up on all overdoses within 48 hours. They do that at-risk proactive intervention, and they also do fatal overdose follow-up. Something that they figured out was that the families were getting left behind when they had a loved one that died from a fatal overdose. And so what they did was not only provide grief counseling for that support, but they would send a card. They would make sure that they knew that they were being thought of, and that type of model has been adopted in a lot of different agencies, and it's really been incredible to see the impact on families and communities that felt so alone and left behind when they lost their loved one. What's really great too with Plymouth County Outreach is that in 2020 to 2021, they saw an 18% decrease in fatal overdoses. They've also had at least 70% of those individuals that they've interacted with accepting some form of services. They distributed a lot of Narcan as well. What we're seeing in 2020, there was a really slight increase in 2022, but in 2023, we're seeing another greater reduction. At a time when we're seeing overdoses skyrocket in other parts of the community, looking at this countywide development that they've been able to do is just really important to think about on how we can tackle these crises. Next slide, please. I want to talk briefly about, I did talk about Coleraine Township, smaller community in Ohio that originally started the quick response team, which is initial follow-up on overdoses, fatal or non-fatal overdoses. Hamilton County, which is in Cincinnati, Ohio, obviously a larger county, a lot more people, a lot different issues going on there. They created a similar QRT, a part of a larger addiction response coalition. What they've done there is just really, really incredible. It's not just the quick response out there, but it's also community engagement and the task force for all of the drug interdictions. They're all housed together and they work together, which is really what we want to see, is this collection of being able to work together. And what they have is 2 to 3 QRT members. That's usually a peer navigator and a non-uniformed law enforcement officer that go out on these non-fatal overdoses and engage. While the state had an almost 25% increase in overdose deaths from 2019 to 2020, Hamilton County saw 11% decrease in overdose deaths. I mean, it's just absolutely incredible what they've done there and the collaborations that they have with their behavioral health partners. They've had more than 900 referrals during this time. They're obviously much higher than that now with current data, but just wanted to show that specific one that was in a research article recently. And that part of that larger addiction response coalition that includes a lead program, which I briefly talked about before, the Task Force Overdose Outreach, and they're also a national COSAP mentor site. And if people aren't familiar with COSAP, it's the Comprehensive Opioid Substance Abuse Program, I think is the substance use. They've just changed it actually, substance use program, which is great. And it's a federal program that offers grants for a variety of different programs in this field. And but as a mentor site, they can do site visits and things like that. So as you're building out any ideas for the community, you can think about all of these resources that are available to physically go and see how they operate on a daily basis. Next slide, please. One more program highlight that's really important is Anne Arundel Safe Stations in Maryland. They, again, started out very small with just a couple of entry points, again, with that mindset of you can walk into a place, but now they have it so you can call a hotline or you can be anywhere. You can be at 1st and 2nd Street and call for resources. And they have a crisis response team that includes a specialty trained CIT officer, a clinician and a care coordinator that responds in the field and connects individuals to resources. They've assessed more than 5,100 individuals since the program began in 2017. They've also shown an 18% decrease in overdoses, a nearly 30% decrease in overdose deaths between 2021 and 2022. A 70% success rate of linking people to treatment. And another great thing is 51% of those that are linked to treatment are still in recovery after 90 days. They have some really robust follow-up mechanisms. What's unique about this program too is that they do have hard data about of what's happening in the community as in response of robberies, burglaries, thefts from vehicles. They've dropped by half, and general thefts have decreased by 28% in that area. Again, it started out small, but now they have those police and fire entry points, and they're able to provide a really robust response to the community. Another great organization to know about. Next slide, please. I briefly talked about the hub situation table model. This is just a few details on it. A lot of we're seeing this pop up a lot. It started in really in Canada, but the first one was in Chelsea, Massachusetts, which was a city that was on the highest on the top 10 most dangerous cities in Massachusetts, and especially in the Boston area. And now they're not even anywhere near that top 10 list, which is really positive for the community. But there are hubs across several of the major cities in Massachusetts, as well as in New York, in New Jersey, Kentucky, and Pennsylvania. I'm really excited to see, especially in some of the rural areas where there's not as many resources like detox centers and things like that. Next slide, please. It kind of just shows like a graph of how it works. There's weekly collaborative meetings. You record the data, including risk factors of somebody in the field. And then there's a process where you filter out who can convene on this and who can intervene. And then there's a follow-up after closing the case. And it's about identifying people who, again, are high utilizers of systems, getting that out there before something like an overdose or more arrest or more ER utilization happens, and being able to co-respond with other agencies in the community that can provide that. We've got some really great resources on that. Again, typically we have that's a 2-day training to talk about it. So I'm just briefly throwing it out here to just show that. Next slide, please. This last part is really what we're seeing in some areas as well. Again, this goes into from Intercept 1 into Intercept 2, but the pre-arrest diversion. There's a lot of resources out there for like Madison Mari program in Wisconsin is a really good example. They have some really incredible programs, but the reason why I show this is that it's the pre-arrest diversion. Other examples, Civil Citation Network, is that a lot of communities are starting to think of the whole spectrum of how we can provide response, from referring to community agencies to maybe a co-response to an overdose outreach, an active outreach bit, and then what happens for those who do end up in the jail system? How can we work with them? It's just showing that these programs will look different depending on those community needs, regulations, resources, but most of these programs have a combination of pathways. And really a combination of pathways is what to be thinking about as you're thinking about these programs in your area. Next slide. I talk a little bit about cost effectiveness and impact, but one thing I also want to bring up as far as opioid settlement funds in general is that PARI in the national agreement, PARI programs are included as an approved use of opioid settlement funds in the national agreement. And the reason why I say that is because all of those programs we've just talked about fall under the PARI program model, that there's no one right way to do it. There's a lot of different programs out there, but just knowing that at the opioid settlement side of it, you have great federal grants as well that are out there like COSUP that exists, but just knowing there's a unique opportunity to be able to utilize and hit some of those core strategies that are listed in that national opioid settlement agreement and in most state agreements across the country. But when we talk about this, about investing money, we know that everybody wants to think about the bottom line and like, how can we save a bit of money? We know we've talked about these programs saving lives. Well, let's talk about the cost effectiveness and impact in general. Conservative estimates talk about addiction treatment will yield a return between $4 and $7 in drug-related crime, criminal justice costs, and thefts. And we know that when we bring healthcare into it, it increases that as well. But we do have specific examples of law enforcement led programs collaborating with the community. Tucson, Arizona is a great example. They just had a recent report out last year that they had a cost savings of $13.40 in personnel alone per incident that they deflected compared to arrest. They projected in this project, this pilot project, that the jail and justice system expense savings were about $640,000. And on top of that, they use less personnel time per deflection, and deflection was more effective than arrest in reducing the frequency of illegal drug use. I think it's just great to talk about because like not only are we looking at, we know that good quality treatment is important and we know that that's there, but how can these deflection programs also save us and be a cost-effective measure for us to invest our money in as communities? A systematic review of deflection and diversion initiatives showed that these programs are effective in preventing future offending and contact with the criminal justice system. There's a good article that's referenced there that goes into a little more research on that, but just want to throw that out there as things to think about as well. Next slide, please. And so we have all of this information. We know what's working. We can see best practices and promising practices. Well, where do we go from here? You've got a lot of great, people who are community minded on this call. I know, especially with, Todd's perspective and him trying to push some of this work, having co-response and things like that so close by. There's a lot of really great resources that are out there. And I think I've got a little block on the screen. I don't know if everybody else is seeing that too right now. There we go. Oh, almost. I can just riff from here if that's okay. Is anybody else seeing the screen? Are you okay? Oh, it's just clicking in now. That's okay. I can keep going if everybody else is okay. I'll just kind of talk through those key points. Really, the big start is identifying those community issues and potential causes. What are you seeing as the main thing that you want to collaborate and try to change? If you have organizational needs assessments, if there's any, a lot of times communities have those different needs assessments and be able to think about that. Finding a champion in each of the agencies that are at the table to really lead the project. If it's going to be law enforcement, fire, EMS based, having that champion there who's really wanting to carry that torch and to move forward with what's next. Department buy-in and cultural change, leadership is really important with that. You may need somebody who's in charge of it overall. In my department, we started very small. I was one sergeant figuring it out. Eventually, we were able to hire social workers in our department, and now we have had a civilian led program at that point, being able to work in tandem with law enforcement. But most agencies start out very small. What we think about too is public safety and public health. I said this in the beginning and I'll say it again here. they're just critical. So understanding the landscape of addiction, collaborating with those treatment facilities, hospitals, those advocacy groups, coalitions for support and guidance is just really important. And developing those local partnerships with judges and prosecutors are really, really important. And really, I should put this in bold letters on my slides moving forward. Engaging people in recovery. They are essential to the process, the program scope. They were so vital in the work that we've done in Kentucky. And they're vital in all of those programs that I've discussed today. There is an aspect of peer support that's involved in each and every one of them. Next slide, please. I put this here as just a checklist for you to take away from this as we're thinking about this and what it could look like and what these programs look. When we're looking around the table, let's think about who doesn't think like us, who doesn't look like us, who doesn't have the same background as us, and get them to the table. This just gives you some ideas of organizations to think about. People with lived experience, first responders, prosecutors, coalitions, faith-based groups, and really a really important part is engaging outreach and deflection programs that are already in existence. Johnson County, Kansas is a great conversation to have moving forward because they've done a lot of the boots on the ground work and be a great place to already start a collaboration. Next slide. There's also a lot of guidance. The White House announces a state model law that was with LAPA, helped develop that as well. This is a link inside the presentation. Everybody should have the slides, but there's a Law Enforcement and First Responder Deflection Act that really shows like ideas for training, ideas for getting started, like who to include and those type of things. It's just a really good reference point to look at as you're building this in your areas as well. And the next slide, I believe, is just some additional resources to consider. I just wanted to put links in there. There's just some really good stuff in there, especially the SAMHSA Connecting Communities to Substance Use Services Guide. There's practical approaches for first responders that talk about a lot of programs and steps and ways to get started. There's just really good reading, and there's lots of free training online and things like that that are really good to have as well. And lastly, what can I do from this point? Obviously, hopefully this little bit of information, I'm happy to take questions. On the next slide, I've got a little bit is about how PARI as an organization, how we can help. It's free to be a member of our organization. We encourage more Kansas departments to join. We have free webinars and state convenings. We would love to have a state convening in Kansas at some point. We just had a virtual one in South Carolina this week, and it's just a great way to collaborate with other leadership across the state that maybe they're already doing something, or maybe they have questions for other resources, so we can all collaborate together. Inclusion on those national discussions that need the voice of police and public safety. We'd like to help with technical assistance, opioid settlement funds guidance. We have our National PARI Summit, and just frankly, it's about connecting with each other. We wouldn't be able to do our resources if it wasn't for all of our other departments out there that are doing the work. I learned from them, they've learned from us, and really that's what the crux of what we're doing here, and hopefully spreading the word to other communities. And the next slide is my contact information. I'm going to take another sip of water because I feel a cough coming on from this, but I really appreciate everybody listening and would be happy to take any questions or anything that you might have for me.
Brittany, thank you very much for the presentation. To me, it illustrated or reinforced some of the things that we're working to do. Are there questions for Brittany from the committee? Lots of information there.
This is Lori. Brittany, I just want to say awesome presentation. Thank you so much for all these good ideas and giving really specific and concrete actions that we could take, and appreciate all the links. So thank you so much. It was really well done.
Thank you very much.
Thanks, Lori. Other questions or comments? Well, Brittany, thank you for your time, even under duress with your cold. As I said, it certainly reinforced some of the things that we're trying to accomplish. It's in my simple way of explaining, one of our goals is to have behavioral health / mental health treated the same as physical health in our response to it. And you know, what PARI does is illustrative of that initial response to an addict or an alcoholic, just like it would be if you found somebody having a heart attack on the street. You know, it's very, you know, the protocols and what to do is already set. But if you find somebody suffering from an overdose on the street, there's, you know, all kinds of questions. And number one is what do we do? So again, I've followed PARI, maybe not quite from the beginning, but along the way is, you know, the things that they're accomplishing. So kudos to you and the organization, and we look forward to including PARI as part of the solution here in Kansas. So thank you, and hope your recovery from your cold goes quickly.
And thank you so much, Pat. I really appreciate that. And I just want to, you know, just echo what you said about that parity of response, and something that Todd and I had talked about for a long time is like, for law enforcement, we have very specific ways that we can handle the community. And I remember those, it was always like, take them to the ER, take them to jail, or leave them for the next shift, right? And those are not the end all be all of pathways that we can have. And if we can create a system that a pathway that allows us to access those resources for behavioral health the same way that we can access dropping someone off at the ER after a car accident, taking someone to the jail after a crime has been committed, and it's the same mechanism, and we're treating that holistically, we're changing the game. And by involving law enforcement in these discussions, we understand more. Like you don't know what you don't know is the way I always think of it. And we can really, with each other, change the way that we're working together. And I mean, I've learned so much by working with my peers, my behavioral health counterparts, that it made me a better police officer when I was still in the field. And I hope that for your communities as well. And the one thing that we did forget to put up, there's an evaluation link. Jenny, do you have a link to that as well? Maybe you could drop into the chat, or we can throw that slide up. Just, you know, if there's any feedback or anything, because I always want to make sure that I'm covering all the bases and helping you all in any way that I can. And it helps the ORN in developing programs and things like that. If anybody wants to do that evaluation link as well.
Well, thank you very much. And we look forward to interacting with PARI in the future. I think we'll move on if there's no further questions or comments.
Thank you all.
Okay, well, and Brittany referred several times to Todd, and Todd's our next presenter from the Midwest high intensity drug trafficking area. And Todd, welcome to the committee, and I'll just turn it over to you, and you can tell us a little bit about your organization and about yourself, and we're anxiously waiting to hear from you.
Oh, great. Good morning. Well, it's tough to follow Brittany. I'm not going to say exactly what she said, but essentially I'm going to echo a lot of it. First of all, if I can say this, you guys are super lucky to have Krista and Alyssa. They are absolutely fantastic. So good job on having them work with you there. They're awesome.
I'll second that motion. I work with them a lot, so
they're great. So essentially, my name's Todd Hickson. I'm a retired DEA agent. I was a police officer in the Dallas area for a while before that, right after I graduated from college. So I've got about 30 years in this line of work. Retired a few years ago, then went back to work for HIDA, and that's a whole long explanation as to what that means. Essentially, the program that I work under is the National Overdose Response Strategy, the ORS. It's essentially it's a partnership between the White House Office of National Drug Control Policy, ONDCP, and the CDC. And so in each state, there's one sort of law enforcement type like me, and then there's a public health person. And my partner is DJ Garing, and then you may have heard of him or heard from him before. He's fantastic. So what we try to do is bring together public safety and public health to try to collaborate on this overdose topic and share best practices, share data, et cetera. So when I talk to law enforcement, the idea is really look at walk and chew gum, right? We got to be able to deal with both the criminal enforcement aspect of the role of law enforcement, which is by law. That's what law enforcement is designed to do, is to enforce the law. Work on some deflection strategies, because at the end of the day, if I'm a police chief, I got my resources. How many resources do I have, and what am I going to do with those resources? And so, in the end, allow to get resources to do other criminal enforcement stuff, as opposed to dealing with someone with a substance use disorder and having to take them to jail and all this other stuff. It's a good strategy to help resources, essentially. It has it's very difficult to for a variety of and so it's if you talk to a police chief in Kansas, I think generally they're saying that.
Am I the only one that's experiencing Todd cutting in and out?
No, Todd, we're getting poor reception.
That's a
Might
word.
be- It might be best just to leave your video off, Todd. I see you have it off now. Maybe that will help save bandwidth.
Lori's more hip than you are, Pat.
That's for sure.
Right. Reception.
I don't know. You look pretty hip today, Pat.
Because my kids were home and they revived my wardrobe. So. Todd, did we lose you completely? We'll give him a couple minutes. Maybe we'll take about a 3 or 4 minute break right now, and then we'll see if we can get Todd back. And if not, we can move on to item number 8. So we'll pause. All right. Everybody is back. Did Todd, was he able to reconnect?
Can you hear me?
Is this Todd?
Yeah, can you hear me?
Yeah, we got you now, and we lost you all together, and I'll let you know if you start cutting out again. Maybe we could just cut off the video, and that way the bandwidth will support the audio part. But why don't you continue where we left off there, Todd? Thank you.
Yeah, guys, apologize for that. I'm actually in a hotel here in Southern California. I'm also struggling. I was forced to be out here away from the 0 degrees in Kansas for a week for a conference. So um, anyway, basically what I was saying is that this is a way to free up resources, programs like this. Overland Park Police Department OPCAT is, this is what they're pursuing. I'm working with them. We're going to go to Michigan. I think I mentioned that. So I would just, the way forward, as I see this in Kansas, I think this is the way forward for law enforcement. This is what law enforcement has to do. And I think that in Kansas, if we get OPCAT up and running on a real robust PARI type program, and they're able to find funding for some of these initiatives, I think this will be the model for Kansas, and then I think you'll see other cities will see this as a way forward. So my strategy is to try to help OPCAT get up and running in Overland Park, and I realize Overland Park is different from everywhere else. But this is a place where they're agreeing to do it on the front end. Other cities have said essentially they don't have any bandwidth. I think once they see this work, they'll see that this is the way forward. So anyway, I really appreciate everything you guys have done in terms of funding these law enforcement agencies. I think it's hugely important. And again, I think that once we can show that this model works, and it's going to take a little bit of time, but Overland Park is very committed to doing it, and they got some great people there. And so anyway, I think we'll see some progress. So I don't want to take too much of your time. It's running late. Anything I can answer for you guys? Anything I can help you with?
Questions for Todd? Todd, just a comment, you know, having been a business guy as well as worked in other endeavors all my life, you know, what's better than getting better results and saving money at the same time. And you, Brittany, before you said a key word that I think kind of drives a lot of where we're heading, and that's collaboration. You know, that's why we're doing the needs assessment, is that, you know, my time in the recovery world, which is quite a few years as all of our board members, is that there's actually a lot of resources out there, both monetarily and just, you know, help. And the more we can do to connect all the resources, the better results we're going to get. We'll get more bang for the buck. And so with what you're doing, I have no doubt that it will be a good model for the rest of the state to follow. So thanks for your efforts there in Overland Park, and look forward to working with them.
Absolutely. Yeah, this is definitely the way forward. And I suspect that you're going to see some applications for funding at some point in the future where there's a formalized relationship between a law enforcement agency and a nonprofit. And I think that's the way forward. That's what they do in Michigan. And I think that's what's going to happen here in Kansas versus people working within their own silos. And I think when you have a formalized relationship, you know, again, it's not my money, but that's what I would put my money on. So,
yeah. Well, thank you very much for the presentation, and have a great weekend. And yeah, I feel sorry for you out there in sunny California.
yeah, we're heading to the beach here in a few minutes, I think. So,
yeah, as soon as I get done with this meeting, that's where I'm heading to. So, well, thank you, and we will move on to item number 8, which is
Pat, before we
yes.
move on, this is Lori. I have a question.
yes.
Brittany mentioned in her presentation that they could do a PARI state convening, and in this discussion of collaboration and you know, learning different police departments learning from each other in Kansas. I just wonder, I know we do grants, but could we as a board choose if we thought that was something valuable to support, to like directly say to PARI, we want to have one of those convenings in Kansas and then support it? I just don't know how that works.
We have quite a bit of leeway, and that certainly would be something that we can talk about, because I've had the same thought, but it also could be part of something I'll bring up at the end. And we talked briefly at the last meeting with Ed O'Malley about the whole collaboration thing and how to facilitate it. And so, yeah, I think that is worth our time as we go forward, you know, especially the meetings here in 2024. You know, we have done a lot of background stuff and we have awarded some funding, but I think it's going to be more and more fruitful. So thanks for bringing that up, Lori, and we'll definitely address that.
Thank you.
Okay, no further questions or comments. We'll move to number 8, and that's the drug courts presentation. I will say that I believe I mentioned a national panel that I was on back. I think we met in 2005 and 6, but a while ago, 20 years ago, and we made 6 recommendations and developed what we called the blueprint for recovery. And I know drug courts at that time was a big part of it, and they were just getting started. So looking forward to the presentation about drug courts. I think our first presenter is Don Huddleston. Don?
Hi, I'm Don Huddleston. I'm actually the statewide specialty court program manager. My position is very new. I just started in March, but I have been a drug court coordinator in 2 different programs for over 15 years in Kansas. And I'm actually here with the 11th Judicial District and their drug court. And I believe Daniel was going to start off with growing resources in rural Kansas, and then I can talk to you more about specialty courts.
Okay. Well, then we'll just get right to Daniel. Where's the 11th Judicial District?
Hello, guys. The 11th Judicial District is it's in Crawford, Cherokee, and Lebec County is the 11th Judicial District. But I'm Daniel Kreitz. I'm Chief Compliance Officer for Community Health Center Southeast Kansas. In healthcare, that's a fancy way of saying I'm an attorney within a health entity. So I'm on the call. Don's on the call. Judge Kreitz out of the 31st Judicial District is on the call, and then another attorney within our organization, Sarah Alnicki, is also on the call. So wide range of people that are happy to answer your questions. I think I'm going to start off and talk a little bit about resources, and then Dawn and Judge Kreitz are going to talk a little bit, and then I'll end, if that's cool with you guys.
Perfect. Thank you.
Yep. So if you'll go to the next slide, I'm going to kind of go through some big picture things, a little bit of history and background. So next slide, please. You know, between 1855 and really 1903, there's a lot of growth in Southeast Kansas specifically. 1903 was a very important time for us. When I'm talking about Southeast Kansas, I talk a lot about 1903 because there's really 3 or 4 big things that happened then. Mount Carmel Hospital was founded then. You would know them as Ascension Via Christi, was founded in Pittsburgh in 1903 on the land that my health center sits on today. It was the first hospital in the region and has great roots to the region. Second big thing was Pittsburgh State University. Regional Iteration was founded a couple months later in 1903. Lincoln School, which is the upper picture there on your left, was also founded in 1903. It was one of the first congregate schools in the region, and actually Out of it grew what's called the Family Resource Center, which is the largest not-for-profit health daycare still in the state that's located here in town. And then the last thing I always like to mention is mining. So we're a big mining community. We're between the late 1800s till about the mid 1920s. There was a study done in about 1910 that showed there was 32 dialects spoken in southeast Kansas. So one of the largest migrations in the Midwest happened where we are. A lot of the bullets prepared for both World War I and World War II were actually made in southeast Kansas through the mining activities. A lot of them actually made it in Parsons. So next slide, please. I'm going to kind of run through these resources and thoughts, and one of the reasons why we collaborate as a health center with a lot of different entities. But data is a big thing. We rely on data to make data-informed decisions and create collaborative initiatives around that. All 9 counties of south of Kansas rank the bottom 25 in Kansas in terms of health outcomes and health factors. Those are generated factors that are submitted to the federal government every year through the Uniform Data System. They're ranked at a federal level, which means that ranking creates the health ranking for Kansas, basically, which Kansas right now, between where we sits between the 34th and 35th healthiest state in the union. If you remove the 9 counties of southeast Kansas, we go from the 35th healthiest state to the 10th. So very limited health resources down here, which is what we're in collaborative efforts, which is what we're trying to do. And then all these counties are designated as HIPSAs, which I'll talk to you about here in a minute. So next slide, please. You guys have seen a lot of this, so I'm not going to dwell on this, and I'm happy to give you additional information on it. But rural Kansas, predominantly live more in poverty, as you guys would know. Crawford County actually is the poorest county in the state of Kansas right now, where we have about 20.5% of our population is living in poverty. Next slide, please. County unemployment rates are getting lower in Kansas trajectory, but in rural Kansas, we're still struggling with that. Crawford County is at about 2.3%. So is Labette. Neosho County is the strongest in the sense that it's about 3.2%. And then Cherokee and Allen kind of fall behind at about 2%. Next slide, please. This is the health factors and health outcomes. This is generated basically through the Robert Wood Johnson Foundation, which aggregates the data at a federal level and then publishes it. So this map is new every year, and it comes based off of the data that health centers around the country. There's about 1,400 of us in the country that submit to the federal government. This is the largest form of public health data in the world, and it's free to anybody. You can get a login and go to UDS and search it out for yourself. But dark colors are bad. So as you can see, the congregate colors in southeast Kansas are bad. So next, and then that health factors is traditionally healthy behaviors, access to clinical care, and socioeconomic factors. So next slide, please. Health outcomes, similar, but this relates more to the social aspects of it, length of life and quality of life. Multiple studies have been done in my region based off of the predominantly how long you live in southeast Kansas. If you are born and raised here, like me and Judge Kreitz are, we are on track to live about 10 less years than if you were born in urban Kansas. So not a great statistic, but that's why we're here doing what we're doing. Next slide, please. And then these next couple slides really go towards how we think through resource development. within my my entity and my collaborative efforts. Population loss is something we trend pretty heavily. This is the percentage of population change, basically from going from rural counties to urban environments. While there has been growth in the sense that there is metropolitan outflow to neighboring counties of big cities like Kansas City and Wichita and Topeka, that is not predominant in rural Kansas, meaning western Kansas or southeast Kansas. So those dark colors are a little bit more predominant, as you can see, in western Kansas and southeast Kansas. Next slide, please. A lot of people, a common reference in healthcare is what's called a HPSA. It's called a Health Provider Shortage Area Designation. This determines whether you're eligible in coming to Kansas or where you locate in Kansas for loan repayment opportunities, either at a federal or a state level at in certain states. Generally speaking, these shortage areas are both for primary care, mental health, and dentistry. And then there are certain sub designations like pharmacy that get rolled in. What you're looking at here in this map and the following one is basically percentage of people living underneath the federally poverty level, along with distance to travel to a provider. And those two things get rolled up with the available resources, meaning the amount of providers in the state, and they formulate a score, which kind of gives you a map in turn of where most of the practitioners are located. So that again, dark colored, not great. So that you look at this map, then if you go to the next one, you're going to see the exact same thing. So predominant location of providers are in the metropolitan areas where you'd expect. And then the last slide, if you'd go to that, we here have 3 functioning residency programs, all that have gotten operational in the last 2 years or 3 years. Pediatric dental residency program with NYU Langone. We have a family practice residency program with University of Kansas. That's on our Pittsburgh campus, very similar to what they do in Salina. And then we have an APRN residency program in Pittsburgh State. So what this map would tell you, generally speaking, is that Kansas produces the one of the least amount of terminal degree professionals in the country. We don't have a dental school. We have fairly limited family practice doctoral slots. So a lot of medical schools, but not a lot of residency opportunities. There's a lot of literature on this, but neighboring states, particularly Arkansas and Missouri, Nebraska, have been a little bit more progressive on that. And so what we're trying to do within my entity and with our collaborations is to grow our minor leagues. That's what this would tell you. So what do these maps tell you as it relates to drug court? It tells you, and as Dawn and Judge Kreitz will tell you, tells you that we have an opportunity to collaborate and grow resources, create pathways out of poverty, and that drug court is an equally good initiative as any to do, as the previous 2 speakers told you, basically interagency opportunities and collaboration on that type of project between healthcare and the judicial legal system. So it's a worthwhile cause that Judge Kreitz has been working on for about 10 years, and so is Dawn. So I'm going to let them talk about, I'll let Dawn talk a little bit about utilization, and then I think Judge Kreitz is going to talk about the 31st.
Daniel, thank you. Great information, and look forward to putting that to use as we go forward. I think we'll just go right to Dawn. Is going to give us an overview, and then we'll have Judge Kreitz tell us about what he's been doing. I know it's some great efforts down there in southeast Kansas, and I know fortunately or unfortunately, when I was at the Commerce Department, I know we had a major effort to make a difference down there in Southeast Kansas, and you guys are, you know, boots on the ground that are making a difference. So Don, you want to hop in here now?
Next slide, please. Oh, and next slide after that. So right now in Kansas, we have really worked to support our initiative to spread specialty courts throughout the state. We currently have 36 specialty court initiatives in 16 of our 31 judicial districts. We have 7 more specialty courts that are scheduled to open in the next year, which will bring us up to, 42 courts and in 18 jurisdictions. We have a multitude of different types of specialty courts. However, there are still many more models that we could be exploring. Right now, our courts are drug courts, adult drug courts, VTCs, veterans treatment courts, and then also mental health courts. We are right now working on a pilot for 3 of the 7 new courts next year, or this year, sorry, are actually going to be family treatment courts, which is a completely different specialty court than really we've ever worked with in the state. Drug courts are where my heart is, and they provide an excellent opportunity in rural communities, especially to bring resources to the client. Probably getting ahead of myself. Next slide, please. The major component of drug court is a non-confrontational approach that, as I said before, it brings the resources to the client. In the past, with the criminal justice system, typically you have a judge that orders that a client complete substance abuse treatment, community service, report for case management meetings. And we know that for those that are experiencing issues with substance use disorder, that is exceedingly difficult. This is the likelihood is that they will end up in jail. And we know that statistically. So instead, through drug courts and all treatment courts, we bring the services that are necessary to treat the individual to the individual rather than require them to go out and look for them themselves. It also brings about collaboration with multiple agencies, which makes the whole system much more effective in addressing the needs of those individuals. There's cross-training opportunities within those teams, and it's beneficial not only to the clients, but it's also beneficial to the community as far as efficiency and use of their resources. Next slide, please. As you'll see here, these are different impacts. There are far more impacts that we could talk about. These are the main ones as far as addressing substance use disorder needs directly, in hopes of breaking cycles of addiction. There's also the financial benefits of producing tax-paying productive citizens and also using community resources more effectively and reducing the amount of re-arrests and reincarcerations. You could skip to the next slide, please. We'll talk a little bit about judicial stats, but before I get to that, I actually also want to make sure that you know that in the state of Kansas, the Supreme Court has supported specialty courts to the degree that they've actually enacted specialty court or Supreme Court rules 190, 191, and 192. And these rules actually provide a framework for standards for specialty courts moving forward so that this can be a major component of our state judicial system. The struggles we encounter is funding. That is the biggest challenge with specialty courts. It is such a new concept that our current funding structure within the judicial branch isn't really set up to support it. There are additional costs to the court that are difficult to find funding for. Right now, we have been looking for grants, and we have 2 committees that are working on a statewide plan to create a plan for sustainability. Excuse me, I have some of the same issue that Brittany had going on. Historically, it's been difficult to staff these these programs, we have a lot of staff that are doing the job that they were originally poised to do and taking on these responsibilities in addition. And that is not sustainable in the long term. We need to do something different with that. Next slide. This gives you an idea of what we see as far as incarcerations. Daniel actually helped with these stats, and there is a great one that's specific to Crawford County. I was even surprised to find out that in a small county, over 400 drug-related probation revocation hearings occurred during this time period. So we're not even talking about all the drug-related arrests. We're talking about just the people that violated probation. There was 400 revocations related to that. And drug courts pose a excellent opportunity to intervene with an effective means of achieving a better outcome for the individual. And what we see nationally is that completion rates of specialty court is significantly higher than probation, which is interesting considering specialty courts are considered way more intense than probation as far as the supervision that they get. Individuals are having weekly, usually more than that, bi-weekly contact with somebody from the court. And there's swift action when there's any issues, yet they still, by and large, are more successful in the long term than those that complete just standard probation. Next slide, please. As I mentioned before, in the US, substance use disorder is more likely to be jailed than treated. That's unfortunate. There's a lot of talk in our own court community about how jails are being used as detox centers now. And that's very unfortunate. 50% of the prison population has a substance use disorder, and mental health disorders are probably they are the biggest underlying concern that are not being adequately addressed when it comes to substance use disorder. And drug courts also provide the opportunity to address co-occurring disorders in that regard, rather than what happens in traditional court settings where the treatment's ordered based on whatever the charge was. So if it was a drug charge, you get a substance use evaluation and you go to treatment. There's not necessarily a comprehensive evaluation of the needs, whereas in specialty courts, that is what happens. Next slide. And now I'm going to turn it over to the judge of the 31st Judicial District so he can tell you about his drug court.
Hey, Claire, I've got a little cold, so I apologize. The other thing I want to clear up, Daniel is our son, but he has a chance in life. He has his mom's looks and IQ, and I want to make that perfectly clear to everybody. We have a great drug court in the 31st Judicial District, and we'll just talk briefly about that, and I'll try and answer any questions. We've been going about, if you go to the next slide, please. We've operated over 10 years now. About 40 participants. I think we had drug court yesterday. We actually have 47 right now. If we get above 50, we're in problems. I don't have enough staff. I don't have enough treatment providers. We make do. We've had as many as 65 before, and we just do the best we can. It's a bi-weekly drug court program between 12 and 18 months. It's post-conviction. Ours is a Senate Bill 123 drug court primarily, and any other related things. We do take other individuals in to our drug court, and to be clear, at least in my mind, the Department of Corrections, to a certain extent, is always worried a little bit about money, and they always seem to expand the drug court population, but the funding doesn't always increase around those edges. And so we take a lot of other people in that we need to, that we think their whole problem may be a situation where it's just all drug related, like burglaries and thefts and that sort of thing. Ours is a felony program, and it's an adult program. We have, and you can go on to the next slide. We've had 176 graduates in our program. Our drug court recidivism rate is 29%. And that's a 10-year period, folks. And If you compare that to the recidivism rate for 3 years from the Kansas Department of Corrections, it's 35%. And so our stats are unbelievable. And that's because we have a great staff that work very hard. They're very dedicated. Tagging off of something that was mentioned earlier, I want to mention that we have a situation now where, the staff in drug court, especially community corrections officers, they do a lot of additional work, a lot of testing, see people a lot more. It's a lot more than somebody just being on felony Department of Corrections probation. There's a lot more responsibilities. But our staff is truly vested in the program. That's why I say we have an awesome staff. They're totally involved in it. But as a result of that, those are the stats. I don't need to repeat those. You can go on to the next slide. Over the last decade, many individuals have been admitted to our program. Not everybody gets through. I mean, that's just the fact. But I think we've turned the tide. And I think this has to do with just having a longevity of a program. And I think we build a lot of trust with the individuals in the sense that they understand we're there to help them. We're there to try and help them recover. And we do everything we can. And in the last 6 months, we've had more graduate that are in recovery and have failed the program. That's a total turn of events for us. It's amazing staff. And again, I thank our staff for that. And I'll be glad to come back later and answer any questions about the creation of our program and any history that you may have. I didn't get my bio in early, and I apologize for that. I am the Chief Judge of the 31st Judicial District, which is Allen, Woodson, Wilson, and Neosho counties. All right, and go on to the next slide. I think we're back to Daniel.
Yeah, and Judge Fleming apologizes that she was going to be here today, but her docket ran a little bit long, so she's in court right now. So I'm going to pitch in for her and talk about the 11th Judicial District Drug Court Initiative, or Specialty Court Initiative, which you guys have supported in a grant opportunity. So next slide, please. Actually, go to the next one if you would. So one of the things I often Judge Fleming would tell you is that the 3 counties that will be addressed by this drug court are all designated as Midwest high traffic drug areas, primarily related to fentanyl, methamphetamine, and marijuana. Those are the 3 predominant in these 3 counties. But there are 15 counties in Kansas that have been designated as that. You can see that they primarily relate to large trafficways in the almost 4,000 miles of projected transportation routes that through 7 states where the Office of National Drug Control Policy has identified as these counties at issue. So next slide, please. When we were Judge Fleming, myself, Judge Stocker, when we talked about drug court over the last couple of years and trying to get it initiated within this district, we've often focused on, Kansas Bureau of Investigation statistics, which again play a role in how what a drug court can do in your community. So there are staggering numbers, particularly related to domestic violence incidents in these 3 counties, which again can play a significant role. Drug use can play a significant role in that. Next slide, please. The Crawford County, Cherokee County, and Labette do have an abnormal amount of out of home placements. We do have one of the highest rates of foster care in the state is actually in these 3 counties. Lebec County, I think, ranks second currently. Foster care, out-of-home placement is something we also pay attention to when you're thinking about the net effect that drug court could have on the family and the ability to keep those kids at home through a structured mechanism. Next slide, please. Where we kind of walking through where we stand today with your assistance, we've hired a drug court coordinator. That coordinator started in December. He came with over 10 years of experience, corrections experience, and worked in one of the jails here for a long period of time. We did, based off of your guys' support, we did, with Dawn's assistance, did file and then have a follow-up and got foundational training for the treatment court initiative through BJA and their All Rise initiative. We were one of 11 awardees of more than 300 applications. So that's a big deal in the drug court world, in the fact that they'll be coming on site in September to Southeast Kansas to help us continue to move the initiative along. So we're really happy with where that sits. As Dawn and Judge Kreitz could tell you as much as me, but there are some federal funding initiatives, both through BJA and SAMHSA. Those initiatives often trail, though, the implementation of drug court. They can trail up to 2 fiscal years, I would say. At least that's how I've been able to trend it. So you do look, but there are those opportunities once you get up and running that you can apply for and hopefully successfully get those opportunities. So I expect that we'll engage both BJA and SAMHSA opportunities here fairly soon. Next slide, please. We're expecting full implementation or initial implementation with a version of a pilot project. I think Judge Fleming's, based off a conversation earlier this week, is thinking sometime in July of this year. And then a full implementation probably likely in the winter, I'd guess around January 1. So on track to start drug court, and I think she'll sign the administrative order probably here within the next month to have that on the ground. So next slide, please. Going back to how we pair our resources together, my health center has worked with Judge Kreitz's 31st Judicial District Drug Court for a number of years. We have been one of his treatment providers. Our staff helps attend his staffing and monitors participants from the treatment perspective, outpatient treatment perspective. But in this district, what we plan on doing is we're going to pair drug court with our existing collaborative efforts. We provide correctional health services in all 3 county jails within this district. So envision that working out very well. So Cherokee, Crawford, and Lebec County, which we started providing correctional services this week, believe that'll work out really well. We also, mental health centers are across the state are implementing the CCBHC model. For those that don't know what that means, that's the Certified Behavioral Health Model, which ran as a pilot federally and is being moved through the state of Kansas now. Those mechanisms do allow for collaboration, increased collaboration in these types of initiatives as well. So we look forward to engaging the 3 mental health centers and having them be good collaborative partners in this initiative. They've played a really good predominant role in the planning stages so far. And then lastly, what we hope to do, Judge Fleming really hopes to do, is we want to engage educational initiatives in drug court. As I said, we try to grow our minor leagues. We have over 300 students of more than 30 different license types that rotate through our approximately 20 clinics each year. So that's nursing, social work, pharmacy, doctors, dentists, everything under the sun. What we've often talked about is that specialty court, given its construction and the way that the judges run the courts, it's a great educational initiative and opportunity for many different practitioners. Social work students come to mind, and then law students come to mind. Law students often do not have great exposure to the court system during the course of law school. Judge Kreitz and I and Sarah could all attest to that. Is certainly something that law schools have worked on, but we hope to pair this program with things like the Third Year Anywhere program, which has been really being pushed by the ABA and Washburn, to allow students the opportunity with temporary licenses to get in the court system in a non-confrontational way and get comfortable there before they graduate from law school. Would be a long-term goal, and I think Washburn is, in our conversations, is very supportive of moving down that avenue. So I think that, next slide, please. I think that was our last slide, but any one of the four of us are happy to answer any questions you have or follow up as necessary. So thank you again for your support of the existing grant opportunities you've given to rural Kansas, and we look forward to continuing to improve resource availability here.
Thank you, Daniel. And we'll open it up to the committee. Any questions for Judge Kreitz or Dan or Don from the committee? Any comments?
This is Lori. I do have a comment and a question. First of all, I want to thank you for your work. It's so important, and I know that you work all very hard with very low resources, and just really appreciate how much effort you put into this. It's critical, I think, to addressing the opioid crisis is this kind of activity. So thank you for your work and your efforts, and thanks for talking to us today. I was wondering, to what extent do you use certified peer recovery specialists as part of the work in your activities?
I can speak for the other drug courts in Kansas. Because of restrictions of finances, we have not expanded into developing a peer support program beyond Veterans Treatment Court, which does have veteran mentors, which is different. That is a priority moving forward. We had like our second statewide meeting of specialty court professionals on our own, and that I attended just yesterday an alumni association presentation and learned more about how they could help with peer support. So we really want to look at doing that. They have great success in some other states by incorporating that into their drug courts.
Yeah, thanks, Don. That sounds like a great area of opportunity.
Other questions or comments?
Yeah, Chair, this is Mike.
Yes, sir.
I'm Mike Brower. This is just a comment, then also a question for Don. But I will point out in Douglas County, the 7th Judicial District, they are using peer supports within their specialty courts. Okay. And that actually is heavily supported by University of Kansas, who's developed a peer support cadre. It's a really neat model, and one that I'm hoping to convince them to expand into Johnson County, but it is the University of Kansas, so to be expanded statewide would be even better. But the question I have though is, so I've been fortunate to be part of a few specialty courts launching over the years. Big advocate for those. Sandra Dixon actually on here has been a big help in some of that work as well. And I think one of the big things that a lot of the courts, especially drug courts, struggle with is funding for treatment, and not just funding for treatment, because I personally believe that these programs should be free to the participants, that they shouldn't be increasing their fines and fees as a result of participating, especially if they're successful. And so that's always a barrier. And not only is the funding for treatment a big barrier, it's the when judge sees someone and knows that they need to get involved in treatment immediately. We can't have them on a 2 or 3 month wait for a block grant dollar bed. And have there, I'm just curious if there have been any kind of discussions at the state level about some opportunities around those costs for treatment.
I recently actually did a survey of coordinators and learned that they have less than a 30-day wait for admission into the program once the client has filed the application. I think a lot of the pause or holdup is we have recognized we actually need to spend more time providing education to the attorneys. Because like I'd said, on the face of it, it looks like specialty courts are way more intense than probation. And I think typically attorneys have been kind of reluctant to get their client involved in such a thing, not realizing or not having the opportunity to learn more about the better outcome their client could have and how to approach that. So we're working on that issue. When it comes to treatment access, we have a multitude of ways to fund treatment and are utilizing. Every specialty court that I have worked with has some form of funding to either subsidize or completely cover the treatment that's here in Kansas. I know that has not always been the case, but it has been kind of, the Supreme Court said if you're going to do this, you're going to do it like the model says, which is make sure that treatment is provided to clients. There is such a, the 11th Judicial District has a really strong plan on how they're going to do it. Other districts, if there's no involvement with community corrections, then court services has to apply for grants to pay for the treatment and use grant funds to do it. If corrections is involved, then they can access Senate Bill 123, but then that narrows the scope of who they can treat in their program. Our VTCs, they all are utilizing VA treatment, but again, then the only individuals eligible are those that are eligible for VA benefits unless they receive other funding to get treatment. So it's all part of the growth process to get these pieces together. And a lot of the difficulty is just finding a resource for everybody to match up with every type of client that could come through. I don't know if that answered your question, but hopefully it helped kind of explain.
I think it gives us just, again, that there's resources out there. We need to be more expedient with the resources, and that's what our committee, one of the things we hope to accomplish is what are all the sources of funding for treatment and for other areas. So thanks, Don, for pointing out what the hurdles are and some of the different sources of funding. Other questions or?
Pat, this is Sandra. Thanks, Mike, for calling that out in Douglas County. Mike was our partner in crime when we were doing this together. In addition to all of that, one of the things we learned in Douglas County is that support for things like housing insecurity, food insecurity, transportation, all of those social needs that are barriers to people accessing treatment, getting to court. So that was really important to engage community partners. And so I know that Community Health Clinic in Southeast Kansas, having worked with them in my old life, are thinking about those types of things as well. But as we think about potential funding, it's not just treatment, it's all those things that surround that patient to help them be successful.
May I add to that statement just for information purposes?
Sure.
She's absolutely right. In the phase progression materials and as well as the ancillary supports for they are actually, I believe, the hardest thing to find funding for, because federal sources, they want you to have these things in your program because they're a best practice, but they don't actually want you to utilize their funds for it, which is really difficult because you're dealing with a government court agency that can't seek donations, can't take in cash donations at all, or even like actual food donations. So we aren't able to do that by statute as an employee. And so it is exceedingly hard to find some way to fund and provide those services. Each court pretty much has to figure out what works for them in their community. And even then, we could do more. We could do better and we could do more with that.
Well, that's a reoccurring theme of different people we have before the committee, and hopefully we can work towards a solution. Appreciate everyone's presentation about the drug courts. As I mentioned, I've been a big drug court fan for over 20 years and look forward to it spreading across the state. And Judge, you hit upon something that's just at the crux. You talked about the graduates of your program there, and I'm sure that is very sustaining in itself, that you see people that come before you that probably have tried lots of ways to get well. Being in recovery, we have a saying that we're not bad people trying to get good, we're sick people trying to get well. And I know that has to be very rewarding to see that firsthand. And Don, Daniel, you work in the area as well. So encourage you to keep moving forward and help people become contributing members of society. And you cited, I can't remember the number, but perhaps if you have people that have been sober and have turned their life around, it'd be, I don't know, for myself anyway, it'd be interesting to know, that number, even some particular stories of somebody that came before you 3 years ago or 5 years ago and how their life has changed around. So thank you for what you do. And I know that drug courts are part of what we're looking for when it comes to collaboration. And so thank you. And I'm sure we'll be hearing more from the drug courts as we move forward.
Thank you.
With that being said, we'll move on to item number 9. Again, thank you for the presentations from the Judge Kreitz and Daniel Kreitz and Don Huddleston and all the rest of the people that presented today. What we have on tap for our next meeting, which my anticipation is that we'll be in person and that we'll have the draft of the annual report, and we can finalize that and take action for that to be submitted. Also, which came up today, and I think it's on everybody's mind, is our next round of funding, what that looks like and how soon that'll happen. And then from our presentation last month, you might remember Ed O'Malley from KHF, the Kansas Health Foundation, presented and talked about potentially some collaboration with KFAB and maybe other entities. And so look for, Ed and I have had several discussions on how we could work together, but also other entities that really are, we're all working for the same thing, and maybe we can combine some resources or at least do a pilot program. So I believe that will be on the agenda to look at and have general discussion within the committee on how we can encourage collaboration, and Ed and I talked about, we want other entities out there to collaborate and to make the most of the resources. Well, we've got to find a way to kind of set by example, our collaboration efforts. So that's what's on tap, and would certainly, if there's other thoughts out there for our February agenda, please send those to me or Krista. But that's what we're looking for at this time. Any other comments from the board? But thank you for your time today. I appreciate the efforts and then just the funding and the RFPs, the 1 and 2 that we've done already. The the work that has gone into those. You know, as a board member, as a board, we certainly, you know, worked hand in hand with Sunflower in particular, and then the folks that they brought on board to go through all the many worthwhile applications, and there were many. Even though we're blessed with funding, it still doesn't go a long way. There's many entities that weren't funded in the first round and the second round, but not because they weren't worthy. It's just that we were limited, and I just feel very blessed to have the staff that we have, and the outside help that we had in the evaluations and the protocols and the kind of the outline of what we were looking for. So thank you to the board on the development of that, and thank you to Sunflower for their efforts in putting that together. With that, if no further comments, I will adjourn the meeting, and have a great warm weekend.
Bye-bye. Thank you.